I'll go ahead and we'll start with opening statements from the ranking member and myself, and I believe Senator Durbin also has some opening remarks, and then we will dive into our witness testimony as well. Since 1999, more than 700,000 people have died from a drug overdose in the United States. Increased opioid addiction and the production of deadly synthetic opioids have exacerbated America's staggering overdose death rates. In 2017, more than 70,000 people died from drug overdoses, making it the leading cause of injury-related death in the United States. Of those, 68% involved prescription opioids and illicit opioids such as fentanyl. Americans fared no better against the opioid epidemic in 2018 when more than 10 million people aged 12 or older abused opioids, 2 million people suffered from an opioid use disorder, and on average, 130 Americans died each day from an opioid overdose. We do not know the sum cost in disrupted lives or untimely deaths from widespread misuse of prescription and non-prescription opioids, but we know from our family, our neighbors, and our friends who bear the enduring imprint of lost loved ones that the opioid crisis is not over. We must continue contending with this crisis. That being said, we've made some great strides over the past 3 years to help combat this crippling epidemic. Congress has passed landmark bipartisan legislation directed at combating the opioid crisis. Most notably, the Comprehensive Addiction and Recovery Act, CARA, and the 21st Century Cure Act, also known as the Cures Act, both of which I proudly supported, were signed into law in 2016. Combined, these two bills provided over $1 billion in funding to combat the opioid crisis, with an emphasis on increasing prescription drug abuse prevention and treatment programs. 2 years later, Congress passed the Bipartisan Support for Patients and Communities Act, which is the most comprehensive anti-drug addiction and trafficking legislation in modern history. We crafted the Support Act to address every element of the opioid epidemic, from manufacturers and distributors through prescribers, dispensers, and users, to first responders and recovery professionals. And to date, Congress has dedicated nearly $11 billion to tackle the opioid crisis, with the largest portion of that funding granted to the Department of Health and Human Services. Today, we will hear from the administration and the executive branch members that shape and execute the government's strategy for combating the opioid epidemic: the Office of National Drug Control Policy, the Department of Justice, the Drug Enforcement Administration, and the Department of Health and Human Services. This hearing is especially important when we think about the oversight role we have in Congress to ensure these executive branch partners are properly stewarding the funding we've provided to them to clearly tackle the opioid crisis. That said, the federal government is just one aspect to combating this epidemic. We do not stand alone. Curbing the opioid crisis relies on wide-scale integrated solutions from all impacted sectors. So today, during the hearing, we will also have the opportunity to hear from key components of the private sector, including the Healthcare Distribution Alliance, National Community Pharmacists Association, Community Anti-Drug Coalitions of America, and drug policy experts from the RAND Corporation. Together, we anticipate a close and comprehensive review of our collective efforts to curb the supply of illicit opioids and unnecessary prescription opioids, to improve access to evidence-based prevention, treatment, and recovery services for opioid use disorder, to identify future needs at federal, state, and local levels, and to develop sophisticated and tailored solutions to this destructive and deadly crisis. Before I turn to our ranking member and esteemed witnesses, I'd like to take a moment to remind us all that America's drug abuse problem did not begin with opioid misuse and will not end with the opioid crisis. In my home state of Iowa, methamphetamine abuse has remained a persistent and perilous problem. Nationwide in 2017, almost 1 million people had a methamphetamine use disorder. That is, they reportedly clinically significant impairment, including health problems, disability, and failure to meet responsibilities at work, school, or home as a result of their drug use. This number is significantly higher than the 684,000 people who reported having methamphetamine use disorder in 2016. In 2016 alone, my home state of Iowa reported over 1,500 confirmed child abuse reports relating to methamphetamine, not just in the home, but being found in the child's body. Folks, ultimately, Americans are suffering from drug dependency. Our loved ones are dying from drug abuse at alarming and distinct rates. Opioids are a priority today, but methamphetamine and other dangerous substances impacting our urban and rural communities should and will be addressed going forward. And thank you, and now I will turn to Ranking Member Feinstein for her opening statement.
Thanks very much, Madam Chairman. I think our opening statements dovetail each other, and I suspect they dovetail what every member of the committee thinks. The question is what to do about it. Just last year, overdoses were created 48,000 deaths. To me, that number is stunning. In 2016, life expectancy in the United States has fallen for the third year, largely due to opioid-related overdose deaths. And the economic costs are just unbelievable, $700 billion a year. One of the reasons it grew so large, I'm told, is a lack of education among medical professionals, which has led to overprescribing. And so we saw in many cases pharmacies were pill mills, with some churning out of millions of pills to smaller communities, regardless of medical necessity. Opioid manufacturers and distributors, I believe, had a responsibility to identify and report these suspicious orders, but they did not. This problem was compounded by inadequate responses from the federal, the state, and local governments. The Trump administration declared the opioid epidemic a public health emergency in 2017, but has only used 3 of the 17 authorities triggered by that declaration, limiting its effect. The Office of National Drug Control Policy, ONDCP, failed to issue national drug control strategies in 2017 and 2018. Its 2019 strategy did not include concrete goals for a 5-year projection for program and budget priorities, both of which are required by law. And according to the October 2019 Department of Justice IG report, the Justice Department and DEA did not initially use all of their existing authorities and resources, reduce quotas for opioids, or hold registrants adequately accountable. The result was an opioid epidemic that evolved from prescription drugs to heroin and ultimately to fentanyl. And there's little question in my mind that the initial response to the opioid situation was ineffective. So how do we get back on track? I very much believe that any solution must include a whole of government approach, and we've got to use all available resources. The Comprehensive Addiction and Recovery Act, enacted in 2016, laid the foundation for this approach. Another bill, the Support Act, was signed into law last year. It built on the 2016 legislation by authorizing critical agencies as well as prevention, treatment, recovery, and enforcement programs, and expanding research. This act also included a provision called the Using Data to Prevent Opioid Diversion. This part of the law is designed to ensure that opioid manufacturers and distributors are held criminally and civilly liable for identifying and reporting suspicious orders of opioids. I happen to be the one that authored that, and I'm very much concerned that it's never been really enforced. So today, I'm introducing new legislation to strengthen this law. And this legislation will require data on all controlled substances to be reported, not just opioids, in order to better identify suspicious orders. It will also require pharmacies to report all transfers of controlled substances to the DEA each month. There is so much to do. The federal government has begun to do this. ONDCP has established a number of interagency working groups, including the National Opioids and Synthetics Coordination Group, big name, to monitor emerging trends and data. The Justice Department created the Opioid Enforcement and Prevention Efforts Division, and that's an opioid fraud and abuse detection unit under a new initiative known as J-Code, focused on disrupting the online sale of illicit drugs. For its part, DEA has increased its tactical diversion squads, enforcement, and administrative actions against negligent distributors and manufacturers. So as a result of these efforts, for the first time since 1990, prescription drug-related overdose deaths decreased. That's really good news. So there are things that we can do to save life and reduce addiction. The Centers for Disease Control and Prevention has warned us a fourth wave of drug overdose epidemics is upon us. Most of those suffering from addiction, they tell us, use more than just opioids. In 2018, cocaine, methamphetamine, and benzodiazepines were present in nearly 60% of all opioid-related overdose deaths. That's a stunning figure to me. So we've got to take a good look at it and see what we need to do. And I would encourage our witnesses today to comment on this. And if you have a solution or thoughts, I think we'd be very interested in hearing them. Our country has been ravaged by an addiction epidemic, and it costs tens of thousands of lives every year. So failure should not be an option. So this is an important hearing, and I so look forward to hearing from our witnesses, hopefully with new ideas and constructive thoughts. So thank you very much, Madam Chairman.
Thank you, Ranking Member. And I would recognize Senator Durbin for opening comments as well.
Thanks, Madam Chair, for this hearing. I called Senator Graham several weeks ago and asked him to consider this, and I thank him and you for making it possible today. I'm not going to state again what's already been stated. We can accept it. We're in the worst drug epidemic in the history of the United States, losing an average in 2017 of 130 people each day. There is no town too small or suburb too wealthy to escape this drug epidemic in my state and across the nation. But it is not the first drug epidemic in our history. The crack cocaine epidemic showed, and I hope that we learned, we cannot incarcerate our way out of this addiction crisis. We need prevention, intervention, and treatment on the front end, not just prosecution on the back end. There's a growing bipartisan consensus that harsh prison sentences for low-level drug offenders have not only failed to stop drug addiction, but have created many unjust and disastrous outcomes. I'm proud this committee spearheaded the passage of the First Step Act to begin to right these wrongs. Now we need to make sure, as we combat current drugs on the market and the spread of synthetic fentanyl analogs, that we do not impede scientific research that can save people who overdose on these drugs, and that we do not criminalize any harmless substances in the process. Let me ask you to consider just this fact. A recent study of fentanyl overdoses in Massachusetts from 2014 to 2016 found that 83% of patients required more than 2 naloxone doses, more than 2. Why? Because naloxone no longer is strong enough to stop an overdose. Researchers have not yet identified an antidote that is. Many researchers believe a more powerful antidote may actually include the drug fentanyl or some analog. That's why I'm proposing legislation that will allow truly harmful analogs to be added to Schedule 1, but not at the expense of facilitating vital research to discover life-saving antidotes. Unfortunately, there's been an effort to bypass this conversation about the research aspects. I hope we can return to it. The second point I'd like to make is this. We can learn an important lesson from the 1998 Tobacco Master Settlement Agreement. Excuse me. The MSA was a landmark $246 billion settlement to hold big tobacco responsible for hooking Americans on nicotine and contributing to millions of deaths. I might add, they're at it again with vaping. But only 8% of the dollars paid under that settlement were devoted to public health harms of nicotine addiction. 8%. Most of the money was spent on unrelated items like roads, stadiums. Many states, cities, and counties have sued the opioid industry, and there's a large, massive lawsuit underway in Cleveland today that could produce a large settlement. I think it's critical that a substantial portion of this settlement be dedicated to fighting opioid addiction. Third point is this. It was in June of 2016 in this hearing room at this very table that I learned for the first time when the acting director of the Drug Enforcement Administration revealed on the record that it was actually the DEA that approved the annual quota of opioids to be produced in the United States. Opioid addiction starts with prescription painkillers made by pharmaceutical companies regulated by the Drug Enforcement Administration. However, the Inspector General of the Department of Justice recently found, and I quote, DEA was slow to respond to the dramatic increase in opioid abuse and needs to more fully utilize its regulatory authority and enforcement resource. For years, DEA permitted pharma to produce enormous, ever-growing amounts of opioid pills each year, even though DEA had the ability to set quotas limiting that production. For example, in 2017, the Drug Enforcement Administration of the Government of the United States of America allowed pharma to produce 13 billion opioid doses to be put on the market. How much would that be? It would be a 3-week prescription for every adult in America, approved by the Drug Enforcement Administration. For years, I've been calling on them to set lower quotas. Last year, Senator Kennedy of Louisiana on the other side and I joined in a bipartisan effort to reform the law and require the Drug Enforcement Administration to adjust opioid quotas to reflect the reality of what is happening in America. Madam Chair, I'm sure that you're well aware of a county in your state, Lee County, that's on the border of Iowa and Illinois. Lee County, Iowa averaged 45 opioid pills per person for nearly a decade, dispensed by one pharmacy in that county. 45 opioid pills per person for every person living in that county for 10 years. In Hardin County, Illinois, one of the least populated counties in my state, about 4,300 people, between 2006 and 2012, 2.7 million opioids were shipped to a single pharmacy in Hardin County, enough to provide every resident with 90 painkiller pills a year. The Drug Enforcement Administration is supposed to monitor this. So they're approving massive production on the front end and no monitoring on the back end, as we see these areas, rural counties, being swamped with opioids. For years, we've been calling on them to lower quotas. Now they have the legislative authority and no excuses. I'm concerned that DEA is not taking this law as seriously as it should, and I'll ask questions when we reach that point. While DEA has lowered the indefensible opioid quotas of recent years, DEA's proposed 2020 quotas do not take into account drug addiction, overdoses, and deaths. In other words, the pharma production quotas don't look at the reality of the worst drug epidemic going on in America today. There'll be some questions on that. I look forward to working with my colleagues, continuing on a bipartisan basis to deal with this. Thank you, Madam Chair.
Thank you, Senator Durbin. Now we'll start with our panel one. We'll introduce our witnesses, and then we will start with witness statement. So with us today on panel one, we have Mr. Kemp Chester, and Mr. Chester is Assistant Director, National Opioids and Synthetics Coordination Group of the Office of National Drug Control Policy. In this capacity, Mr. Chester leads interagency efforts to reduce the availability of heroin, fentanyl, and synthetic drugs in the United States by disrupting its global supply chain. We also have Ms. Amanda Liscombe. Ms. Liscombe is Director of Opioid Enforcement and Prevention Efforts for the United States Department of Justice. Ms. Liscombe is responsible for coordinating the department's strategic responses to the opioid crisis, including all investigative and prosecutorial efforts. We also have Mr. William T. McDermott, Tim McDermott. Mr. McDermott was appointed as the Assistant Administrator to DEA's Diversion Control Division on July 24, 2019. He serves as the Principal Advisor to the Administrator on all matters pertaining to the regulation and coordination of programs associated with the diversion of legally produced controlled substances and listed chemicals. And then please help me with your name, Dr. Neeraj Gandrotra. Serves as the Chief Medical Officer with the Substance Abuse and Mental Health Services Administration. He is familiar with the development and utilization of medical services budgets, nuances of regulations and code across various states, and provider perspectives as he delivers direct patient care. Thank you very much, Dr. Gandrotra, for being with us today. We will go ahead and start with our witness statements. We will start with you, Mr. Chester.
Chairwoman Ernst, Ranking Member Feinstein, members of the committee, thank you for inviting me to testify on the dynamic and challenging illicit opioid environment we continue to face in the United States and our whole-of-government approach to addressing it. The Office of National Drug Control Policy, under the leadership of Director Jim Carroll, is uniquely positioned within the Executive Office of the President to coordinate the administration's comprehensive approach to drug policy development and implementation. When ONDCP began work on the opioid issue, the dominant threat was heroin. At relatively low prices and in purer forms, which allowed for non-intravenous use, heroin enabled an easy transition from prescription opioids to illicit opioids. Fentanyl emerged as a major overdose driver in 2015, initially as an adulterant to heroin, but by mid-2017, many states had experienced a crossover where more people were overdosing and dying from fentanyl than from heroin exclusively. Today, we see even more diversification across the illicit opioid environment with a variety of fentanyl analogs and non-fentanyl synthetic opioids readily available, some pressed into highly sophisticated counterfeit pills, sold on the darknet, and delivered direct to consumers. This is further complicated by user transference among different drug types and across both synthetic opioids and non-opioid drugs like methamphetamine. Combating illicit opioid availability and use demands presidential leadership, strong bipartisan support from the Congress, and the synchronization of international, federal, state, local, and tribal partners across the public health, law enforcement, national security, and intelligence communities. This allows us to deeply understand the environment in all its complexity and quickly identify and then rapidly close gaps in our capability as they emerge. Over the last 4 years, the federal government has made life-saving gains through the synchronized approach first laid out in the 2016 Heroin Availability Reduction Plan, then the final report of the President's Commission on Drug Addiction and Opioid Abuse in 2017, President Trump's initiative to stop opioid abuse in 2018, and the 2019 National Drug Control Strategy. We advance our policy objectives along 3 clear lines of effort: prevent drug use before it starts, improve access to treatment leading to long-term recovery, and reduce the availability of illicit drugs in the United States. Most importantly, the strategy guides and synchronizes federal government actions on the entirety of the drug problem to achieve our singular goal of saving American lives. This is the only criterion that truly matters and by which the American people will measure the success of our efforts. These foundational documents and the efforts they articulate have enabled significant accomplishments over the last few years. The creation of the Department of Justice's Joint Criminal Opioid and Darknet Enforcement, or J-Code team within the FBI, to target the internet trafficking of synthetic opioids. The training and deployment of K-9 teams throughout Customs and Border Protection's Office of Field Operations, specifically trained to detect fentanyl. the establishment of a 24-hour, 7-day teleforensic capability for CBP under the Interdict Act to identify new synthetic opioids as they emerge in the marketplace, and the passage of the Historic Support Act, which recently authorized new Medicare Part B benefits that allow opioid treatment programs to bill for their services, including counseling and medications, beginning next month. However, the illicit opioid environment continues to present a daunting challenge. Synthetic opioids shipped in small quantities make detecting and seizing these drugs monumentally difficult as they move through the mail, express consignment carriers, and across our borders. The increasing prevalence of polydrug users, counterfeit pills, and the rapid emergence of highly addictive, deadly, and readily available synthetic opioids are impacting prevention and treatment efforts. And as China's efforts to address the illicit production through class-wide fentanyl scheduling begin to take hold, new production sources and distribution vectors are emerging. These challenges are not insurmountable. And now more than ever, our efforts must remain synchronized across the entire government, with our state partners, our partners in the private sector, and others to produce the complementary effects we need to end this crisis. I would like to thank this committee for your foresight and leadership in addressing this critical national security, law enforcement, and public health challenge. On behalf of the administration, ONDCP looks forward to continuing to work with you to confront this extremely complex issue. Thank you for the opportunity to testify today, and I look forward to your questions.
Thank you, Mr. Chester. Ms. Liscombe.
Chairwoman Ernst, Ranking Member Feinstein, and members of the committee, thank you for the opportunity to discuss the Department of Justice's work to combat the opioid epidemic. I am the department's Director of Opioid Enforcement and Prevention Efforts. My position in the Deputy Attorney General's office was created for the sole purpose of ensuring that the department is properly formulating and implementing resources to the fullest extent with the express goal of combating the opioid crisis. I also have 13 years of experience as a drug prosecutor, working as an assistant United States attorney and also as a deputy section chief in the department's criminal division. I know firsthand that the department is not simply paying lip service when its leadership expresses its commitment to stem the tide of this epidemic. It is responding aggressively and intentionally with every tool that it has at its disposal. One such tool is focused on the department's effort to dismantle darknet websites. These websites allow some of the most prolific drug suppliers to sell fentanyl on their marketplaces. Dismantling them is a priority for the department, which is why in 2018 the FBI established J-Code, or the Joint Criminal Opioid and Darknet Enforcement Team. Since J-Code's launch, there have been 2 successful large-scale takedowns that have taken dozens of darknet accounts off the web and hundreds of kilograms of drugs off the streets. The department has also been diligently working to prosecute Mexican cartels who traffic fentanyl and fentanyl analogs into the United States. The Mexican cartels are not only producing their own fentanyl, but mixing it with other drugs such as methamphetamine, heroin, and cocaine, which is contributing to the staggering numbers of overdose deaths throughout this country. The department is using all of the tools at its disposal to combat these cartels, most notably winning the conviction of Sinaloa cartel leader Joaquin El Chapo Guzman Loera, who was sentenced to life plus 30 years in July of this year. Another noteworthy initiative is Operation Synthetic Opioid Surge, or SOS, that focuses on illicit opioids in 10 districts that have seen some of the highest overdose death rates in this country. The prosecutors in those districts work towards prosecuting all readily provable cases involving synthetic opioids. In the first year of this program alone, over 300 cases were charged in these 10 districts. Additionally, the department has created the Appalachian Regional Prescription Opioid Strike Force, also known as ARPO, a joint law enforcement effort that pools the resources and expertise of multiple agencies to identify, investigate, and prosecute healthcare fraud schemes in the Appalachian region, one of the most hard hit by this epidemic. Since its October 2018 establishment, the ARCO Strike Force has charged more than 70 defendants who are collectively responsible for distributing over 40 million pills. These medical professionals were charged with drug trafficking offenses with stiff penalties for their diversion of opioids. The ARPO Strike Force has also worked hand-in-hand with HHS to ensure that when there is a takedown of these medical professionals, patients are not left out in the cold. Rather, they are met by a team of public health officials who can refer them to legitimate medical providers or addiction recovery services. The department recognizes that we cannot simply prosecute our way out of this crisis and have been using our resources to help prevent opioid abuse before it takes place. This occurs through school and community outreach, partnership with Native American tribes, public service announcements, and training for medical professionals. Additionally, the department has a robust grant network established exclusively for opioid abuse and overdose prevention. This includes grants to help facilitate youth treatment, prevention, and victim services, and help state and local law enforcement better investigate heroin and prescription opioid distribution. Finally, I want to remind you of what I spoke with you about in June, the importance of a legislative solution for class-wide scheduling of fentanyl-like substances. While the nation has seen the usage of prescription opioids decrease, the number of overdose deaths in the United States has reached record levels. One of the chief causes is the proliferation of fentanyl and its analogs. As you know, in February of 2018, the DEA responded to the proliferation of fentanyl analogs by scheduling the entire class of fentanyl-like substances on a temporary emergency basis. In response to this class-wide scheduling order, we've seen a significant decrease in encounters of fentanyl-like substances and a reduced production of these substances by traffickers. Class-wide scheduling is working, but the temporary emergency scheduling order expires in just 51 days. As a prosecutor, I can tell you that legislation to permanently schedule fentanyl-like substances is an important and necessary step to continue countering this epidemic. We are running out of time, and if a solution is not found, prosecutors will undoubtedly be hindered, and traffickers will undoubtedly be helped. We cannot afford to move in the wrong direction while battling this crisis. Thank you for the opportunity to testify today, and we look forward to continuing to work with Congress to find solutions necessary to address the threats posed by this epidemic.
Thank you. Mr. McDermott.
Chairwoman Ernst, Ranking Member Feinstein, and distinguished members of the committee, on behalf of the 9,000 men and women of the Drug Enforcement Administration, thank you for the opportunity to discuss our response to the opioid crisis. Over the past several years, our nation has been increasingly devastated by an epidemic that was fueled by the overprescribing of potent prescription drugs. The increase in prescribing from the late 1990s through the first decade of the 2000s was fueled by a fundamental belief that pain was undertreated in the United States. Indiscriminate prescribing during this time created a generation of opioid users, presently estimated at more than 3 million Americans. Unfortunately, as prescription rates have declined over the last 4 years, we have seen a dramatic and disturbing shift. Mexican drug cartels are filling the void with cheap, highly potent white powdered heroin. They continue to mix it with illicit fentanyl and selling it to users in both the traditional form and now, in many cases, pressed into counterfeit pills made to resemble illicit pharmaceuticals. DEA is now seeing Chinese and Mexican nationals working together to move massive amounts of heroin, fentanyl, fentanyl-related substances across the southwest border. The profits that these organizations are collecting are astounding. A kilogram of fentanyl can be purchased for less than $5,000 and can yield potential profits from its sale in excess of $1.5 million. DEA believes that the Sinaloa cartel and CJNG will continue to be the primary Mexican cartels controlling the illegal drug distribution throughout the United States. These cartels do not observe boundaries or laws in Mexico, the United States, or any other country. DEA will continue to focus its attention and efforts on the command and control components of these major drug trafficking organizations in order to protect our citizens from the devastation that they bring in the form of violence and drugs. With respect to addressing the diversion of controlled substances and prescription drugs, I oversee the activities of DEA's diversion control program, roughly 18% of our workforce. The diversion of prescription opioids by a small number of practitioners, less than a fraction of 1%, have disproportionately impacted this epidemic. In fact, 4 out of 5 new heroin users state that they started their cycle of addiction on prescription opioids. Within the diversion program, we have realigned criminal investigators embedded them alongside diversion investigators in an effort in enforcement groups we call tactical diversion squad groups.
Currently, we have 86 of these groups nationwide who are solely dedicated to investigating, disrupting, and dismantling individuals and organizations involved in diversion schemes. These groups, along with an additional 87 diversion groups, are using all tools, administrative, civil, and criminal, to pursue those registrants who violate the law. We also remain focused on the limits DEA establishes for domestic manufacturing of Scheduled 1 and 2 controlled substances called quotas. With the recent publication of the 2020 quotas on December 2nd, the DEA has decreased quotas for the 6 most frequently misused opioids by 55% from the levels established at the end of 2016. We have been able to bring down these quotas because doctors nationwide are writing less prescriptions for opioids, a 30% decline since January of 2017. Despite these declines, let me assure this committee that we recognize that opioids are essential medicines, especially for those with acute pain. And DEA will continue to work with FDA, the Centers for Medicare and Medicaid Services, CDC, and the state AG's offices to ensure that there are adequate supplies for those in need. The division is continuing its robust outreach program with registrants aimed at improving communication and cooperation. In closing, I want to thank you for the opportunity to be here today, and I look forward to your questions.
Thank you. Dr. Gendotra, please.
Chairwoman Ernst, Ranking Member Feinstein, and distinguished members of the committee, thank you for inviting me here today to discuss SAMHSA's approach to the opioid crisis. I'm Neeraj Gandotra, and I'm Chief Medical Officer for SAMHSA. I'm an addiction psychiatrist with expertise in multi-site, multi-state operations, provider supervision, and the treatment of both mental illness and substance use disorders in vulnerable and underserved populations. SAMHSA's core mission is to reduce the impact of substance misuse and mental illness in communities across this country. We are the agency within HHS that leads public health efforts to improve the lives of individuals living with mental illness and substance use disorders, as well as their families. SAMHSA's #1 priority in combating the opioid crisis is the expansion of prevention, treatment, recovery, support services. We do this by providing a full range of grants targeting the opioid crisis. The State Opioid Response Grants, or SOAR, program addresses the opioid crisis, including prescription opioids, heroin, and illicit fentanyl and fentanyl analogs, by increasing access to medication-assisted treatment, or MAT, using the 3 FDA-approved medications for the treatment of opioid use disorder, reducing unmet need, and reducing opioid overdose-related deaths through the provision of prevention, treatment, and recovery activities for opioid use disorder. SOAR grantees partner with numerous community providers and other stakeholder organizations to ensure the dissemination of appropriate evidence-based opioid prevention strategies. These include drug take-back and disposal programs and overdose education, as well as naloxone distribution activities and marketing media campaigns and strategies to reduce stigma. In order to ensure that individuals receive a comprehensive array of services, SOAR grantees also provide recovery support services. One of the most common approaches to implementing recovery support services by SOAR grantees is the utilization of peer supports, individuals who themselves are in recovery. Another common activity is the development, enhancement, and expansion of recovery community organizations, as well as the use of recovery residencies. Peers are engaged in a number of settings where individuals with opioid use disorder initiate and maintain recovery. SAMHSA strongly believes that the expansion of comprehensive systems of care through continued partnership between federal government, state, and communities, we will make continued progress in combating the opioid crisis. American Indians and Alaska Natives have been especially hard hit by increasing rates of prescription and illicit opioid use, addiction, and overdose as well. These populations have the 2nd highest overdose death rates from heroin and the 3rd highest from synthetic opioids. In an effort to address the opioid epidemic in Indian country, SAMHSA has established the Tribal Opioid Response, or TOR program, through a SOAR set-aside. The TOR program aims to address the opioid crisis in tribal communities by increasing access to culturally appropriate and evidence-based treatment. SAMHSA has also been a leader to reduce overdose deaths by increasing availability and use of naloxone to reverse overdose through funding and technical assistance. SAMHSA's Overdose Prevention Toolkit, released in 2013, is one of our most downloaded resources. The toolkit provides information on recognizing the risks of opioid overdose, the signs of overdose, and how to provide emergency care in an overdose situation. The toolkit is intended for community members, first responders, prescribers, people who have recovered from an opioid overdose, family members, as well as communities and local governments. SAMHSA's opioid prevention efforts targeting prescription drug misuse have also shown positive outcomes. SAMHSA's strategic prevention framework, prescription drug programs, assist grantees to target the priority issue of prescription drug misuse. The program works with pharmaceutical and medical communities on the risks of overprescribing to young adults and brings prescription drug abuse prevention activity education to schools, communities, parents, prescribers, and patients. All the grantees are required to have an operational state-run prescription drug monitoring program called PDMP, and are supported in developing capacity and expertise in the use of data from these PDMPs. SAMHSA's National Survey on Drug Use and Health, also known as NSDA, provides key national and state-level data on a variety of substance use and mental health topics, including opioid misuse. It's a vital part of surveillance efforts related to opioids. SAMHSA is also building existing partnerships with NIH, a primary partner in implementation of Healing Communities Project, to improve research to practice pipelines, and is committed to promoting evidence-based practices and service delivery models. Thank you for the opportunity to testify on this issue. I look forward to answering any questions you may have.
Thank you again to our witnesses, and we will start with 5-minute rounds now within the members. And Dr. Gandotra, I'd like to start with you, please. According to the U.S. Census Bureau, rural areas cover approximately 97% of the nation's land area, and approximately 56% of Iowans live in those rural communities. And we heard from, of course, Senator Durbin as well, outlining some of his rural communities. And Dr. Gandotra, in your written testimony, you highlighted the Substance Abuse and Mental Health Services Administration's work in those rural communities, and thank you for doing that. Can you describe some of the key challenges to reducing the impact of substance misuse and mental illness in rural communities, especially when it comes to opioids, and then if you can also speak to us about methamphetamine as well?
Thank you. Thank you for the insightful question. I believe the focus is treatment capacity. We certainly do have a great number of providers. They need to be in the right places. Treatment capacity is certainly addressed by a variety of different techniques. Telehealth is one of the areas that we're certainly exploring to increase capacity to these rural areas, as well as provider expansion. SAMHSA, in collaboration with the DEA, has certified a large number of waivered physicians and providers, including expansion for our nurse practitioners and physician assistants in mid-levels, increasing provider limits so that they would be able to treat a greater number of patients. So we are understanding that we have to attack this problem from different angles, as well as including provider education for our primary care colleagues as well. I would comment that our Addiction Technology Transfer Center has provided over 50,000 providers with the expertise in attacking this problem as well. So education and treatment expansion, as well as exploring opportunities with telehealth, would be the ways we would most likely proceed.
Excellent, and I appreciate that. In Iowa, I have visited various community health centers, and they are expanding their reach through telehealth, and really appreciate you speaking to that. And then beyond the opioid epidemic, what is SAMHSA's long-term strategy then for addressing substance misuse and mental illness in those rural communities?
So the the issue of addressing substance use, we certainly have a lot of resources that we're devoting towards that, and we thank Congress for the appropriation with the substance abuse block grant funding in particular. Block grant funding can be utilized for the treatment of any substance use disorder. In addition to the SOAR grants, which also can be used to treat opioid use disorder and any co-occurring mental illness or substance use disorder. A great number of enrollees do have co-occurring substance use and mental illness, and certainly funds can be are appropriated for that as well.
Very good. And Mr. McDermott, DEA is our nation's frontline defense to illicit controlled substances. And we've just recently marked the 1-year anniversary of our bipartisan legislation, the SUPPORT Act, which combats the opioid epidemic. And I worked in that measure to strengthen drug take-back programs, their efforts, and increase safe disposal of drugs. And how can DEA work to increase the participation in those drug take-back programs? Maybe hit your button again there.
Senator, sorry.
Thank you.
What I can tell you is that twice a year DEA does the take-back, once in the spring and once in the fall, and it's been very productive. Most important thing I can say about that is this, is that typically when an adolescent is involved with abuse of opioids, typically it starts in the medicine cabinet. And that is the most important thing to get out of your house. They have these pill parties at schools and so forth that you've probably heard about. So if we could get the message out, and we're doing it a much better job, I can tell you now, with the participation from tribal areas as well, and the addiction rates there are tremendous. I was the SAC in the Denver area, and we covered Montana, and we had serious concerns there. So take-back has been very productive. We have more participation from state and locals. We also have participation from coalitions. We have participation from hospitals, you name it. And so we're out there, and it's been a very productive. And at the end of the day, sometimes there's criticism to say we only get X amount of opioids, but I can tell you, any amount of opioids that you take out of your house or off the streets, that is beneficial.
Right. Thank you. Ranking Member Feinstein.
Thanks very much, Madam Chairman. I believe that the chairman of this committee and I very much believe that fentanyl should be made a Schedule I drug, and hopefully we'll proceed to do that. I can't believe that 48,000 overdose deaths. Can you in any way, shape, or form give us the constituency for those 48,000 deaths? In other words, who is dying? What is their age? What is their race? How do we know who they are?
Yes, Senator. I will tell you that one of the defining features of the opioid crisis, and specifically overdose deaths due to illicit opioids, are the fact that it cuts completely across racial, economic, geographic, gender lines. A lot of the drug overdose and use patterns that we saw in years past are defied by the fentanyl crisis because it's introduced into the marketplace, into users in much different ways. Sometimes, as it's mixed in as an adulterant to heroin, it lands in the existing intravenous drug-using population. If it's pressed into a highly sophisticated counterfeit pill and sold on the internet, perhaps to an unknowing user who thinks that they're just getting cut-rate opioids from another country, it's a person that does not understand or know that they're being part of the illicit environment, but they're getting a pill pressed into getting a fentanyl pill being presented as a counterfeit drug. So it cuts across all racial, geographic, and demographic lines, and that is one of the defining features of this particular crisis.
Would anyone on the panel not support fentanyl being made a Schedule I drug? So I assume the answer is yes. And Madam Chairman, I believe very strongly, and the Chairman and I have discussed this, that fentanyl should be made a Schedule I drug as soon as we possibly can. I think 48,000 people dying from it. Can anyone give us a description of the deaths and the majority of use involved in those deaths?
Senator, I can start, and then
Okay, go
others
ahead.
can
Thanks, Mr.
can fill in if they'd like to. One of the things that we've seen in the evolution of fentanyl, and I think I touched on this in my opening statement, is that there was, in 2006, there was a small outbreak of fentanyl overdose deaths in Illinois, and that was tracked back to one single lab in Mexico. The lab was neutralized, and fentanyl didn't completely go away, but it certainly decreased. And it really wasn't until 2015 that we started to see it be a regular feature in postmortem toxicology testing, then in drug seizures. By that time, Asian drug traffickers, principally from China, had entered the scene and were bringing it into the country, principally being ordered over the dark net and then sent through mail and express assignment. And the reason I say that is because rather than having individuals having to go to drug traffickers and make a face-to-face cash transaction, it was now able to be diffused across the country, and anyone with access to a laptop and the dark web and cryptocurrency could buy it and have it delivered directly to their house. And this kind of speaks to the proliferation of illicit opioids and fentanyl across the country. What was originally started in the Northeast as it involved the intravenous drug-using population, then expanded across the country to where we are today.
So any newly discovered fentanyl substance should be added to the Controlled Substances Act by name. Would everybody support that? Anybody disagree? So, Madam Chairman, I mean, I think we have our work laid out for us, and Senator Durbin, I know, has thoughts on this, but that we work to make fentanyl a Schedule I drug and try to reverse these deaths. Is there any common denominator of people in the 48,000, racially, economically, age-wise?
Not too many common denominators. I think some of our state partners with whom we deal and provide us a lot of information have spoken to perhaps an increase in the African American community above what we saw in other opioids. The only common denominator for everyone who has died is the availability of the drug. And availability, we know, leads to increased first use, and first use leads to chronic use with opioids, perhaps more so than any other drug, and that's the common denominator.
Do you support making it a Schedule I drug?
Yes, ma'am, absolutely.
Does everybody on the panel support making it a Schedule I drug? Would you like to comment?
Senator, I don't, I'd have to take that back to the department and have our Legend Affairs work with you further on that.
I don't want you to get in trouble. Mr. McDermott?
I agree with Ms. Lipscomb.
I also would like to take that question back to my
Well,
HHS
if you
colleagues.
would, I would certainly appreciate an answer because that's where I'm going. In any event, may not be successful, but it's what I deeply believe. Thanks, Madam Chairman.
Senator Grassley.
The Office of Inspector General recently reviewed the DEA's efforts to control the diversion of opioids. The report did this conclusion, quote, the DEA was slow to respond to a significant rise in the use and diversion of opioids since the early 2000s, end of quote. So, Mr. McDermott, the Inspector General's report states that, the, quote, the Department and DEA agreed with all the recommendations. How is DEA prioritizing and meeting these recommendations?
Senator, as we speak today, we're working on those. One of them is there was criticism of DEA pertaining to our work plan for diversion investigators. We have changed the work plan. We have worked with OIG, and we have implemented their recommendations as we speak today.
Okay. And then I think the next question to you is easy to answer. Would you commit to update Congress on the progress of meeting these recommendations?
Yes, sir.
Okay, thank you. Last year, Congress passed landmark legislation addressing the opioid crisis. We call that the Support Act. I'm proud to have co-sponsored and moved through the Judiciary Committee as chairman at that time, number of bills that are part of that law. So, Ms. Liscombe, the OIG report states that because the Support Act is relatively new, the Justice Department is, quote, unable to measure or even predict its effect on the opioid crisis or DEA's opioid enforcement efforts. Question, while that may be the case, and maybe legitimately the case, the Director of Opioid Enforcement and Prevention Efforts at the Justice Department, that's your position. Can you provide anecdotal evidence of success of the federal government's efforts to end the crisis?
With respect to the Support Act or in general, Senator?
No, with respect to the Support Act.
Sure. So the DEA has implemented a number of the asks from this Support Act, specifically the Suspicious Order Database that was implemented on October 23rd of this year. And I know that they are still working through a number of other components within the Support Act to include their work with the ARCOS database, which has been invaluable to the department with respect to our opioid investigations. I can tell you I've seen firsthand how these types of databases have been used to successfully prosecute the diversion of opioids, both with what we refer to as dirty doctors to nationwide opioid manufacturers and distributors. And so we are working with DEA to ensure that we are able to hit those benchmarks with the Support Act.
Okay. Since I'm going to ask this question of the entire panel, and it deals with fentanyl, and I hope it doesn't cross over what Senator Feinstein asked. It's well known about fentanyl and its dangerous analogs coming to the United States from China. In April, China issued a class-wide control of fentanyl analogs. Also earlier this year, witnesses from DEA, the Justice Department, and ONDCP commented at the Judiciary Committee hearing that they're monitoring China's actions and ensuring follow-through. To all of you, what significant developments at each of your agencies show the American people that we're winning the fight against Chinese fentanyl entering our country? I'll start with you, Mr. Chester.
Yes, Senator, I think a couple of things have come together to bring some tangible outcomes from China's efforts to schedule fentanyl as a class. The first one is the President's direct appeal to President Xi, asking him to class schedule, was an absolute game changer. Ambassador Branstad's leadership and his coordination with the administration and the interagency, I think, has been incredibly important. And that resulted in China not only following through completely on its 1 May commitment, but also taking some tangible steps, such as 2 months ago, inviting U.S. officials to the conviction of 9 individuals for fentanyl trafficking coming from China, which was a major step forward. As you know, Director Carroll traveled over to China in September, spoke with the Chinese government about some tangible steps that they could take moving forward to include greater law enforcement cooperation, greater policy coordination, and we believe that the steps in China are positive and will take us in a path where they will begin to reduce the flow of fentanyl coming into the United States.
For the rest of you, if you have an answer, make it short because my time has run out and I don't want to infringe upon the other people. Ms. Liscombe?
Just briefly, it's my understanding that we've seen a significant drop-off in the amount of fentanyl and analogs coming from China through the mail, which shows the positive steps that have been taken from China's class-wide scheduling. And I would just remind the committee that since the temporary scheduling order went into effect, we have in the United States seen a significant drop-off of analogs in this country. I believe there's only been 2 analogs that have been encountered in this calendar year, which shows that both China's actions and the actions here in the United States are working with respect to fentanyl analogs.
Mr. McDermott?
I echo her comments, and also we have 2 offices in China right now. DEA does. We have one in Beijing and one in Guangzhou, and the working relationship has been excellent.
Do you have anything to add, Doctor?
Simply that SAMHSA's approach has been for prevention. We've distributed naloxone kits, and certainly over 250,000 of them have distributed across the country with reversal of over 14,000 overdoses.
Thank you, Madam Chairman.
Thank you. Senator Durbin.
I want to make sure the record's clear that in 2016, when we had a hearing before this committee, we established the Drug Enforcement Administration had approved the production of 14 billion opioid doses that year in the United States. 14 billion. That meant that every adult in America could take a 1-month prescription of opioids based on the approved production quota from the Drug Enforcement Administration. We were in the midst of the worst drug epidemic in our country. We still face it. Opioids were driving it to heroin and fentanyl, and the DEA was approving the production of 14 billion of these doses requested by the pharmaceutical industry. A number of us started asking questions. What is going on here? Why are we producing all these opioid pills, dramatically more than is necessary for the health of America? And as a consequence, Mr. McDermott's testimony today is that the quota productions have gone down, some 55%. I don't know what the exact number is. I'm estimating it's around 8 billion at this point. 8 billion opioid doses a year. What is that equivalent to? It is equivalent to a 2-week dosage for every adult in America. That is what we are still producing in opioids as we talk about all the consequences of the opioid drug epidemic. And so, Mr. McDermott, Senator Kennedy and I said, what's going on here? Is the DEA paying any attention to what's happening to these opioid pills once they're produced? And the response to me was, Senator, if you want us to pay attention, put it in the law. And we did. And we said from this point forward, when they set the quotas at DEA, take into account the deaths in America related to opioids, the diversion of these opioid pills from the ordinary medical course of commerce, and the following. And so we waited to see, Mr. McDermott, what would happen. And you know what the response was from the DEA? We just can't find that information. We can't really take that into consideration. In fact, the DEA basically told us, DEA determined that due to the grouping of drug classes and all sources provided, the data could not be used to estimate diversion for the purpose of setting the production quotas. What does it take? How do we get the DEA to acknowledge that 8 billion opioid doses is dramatically more than could possibly be used for legal purposes, for medical purposes?
Senator, thank you for your question. As previously discussed by the former acting administrator, DEA realizes that we could have done things differently.
Yes.
We are doing things differently. I've been in this position for almost 3 months. I read your letter and Senator Kennedy's letter, and I will tell you that I sat down with our folks that do quota, and we went over the numbers again. I assure you that it is a priority for me, and I assure you it's a priority for the administrator to ensure that we have a balanced approach. And we are looking at those. If you look at the numbers, I think we're doing exactly what you asked us to do. We've reduced
8 billion, enough for every adult in America to have an opioid dose for 2 weeks? Every adult in America? You think that is a good response in the midst of a drug epidemic?
Sir, we work with HHS, we work with FDA, we work with the CDC, we work with the State Attorney General's offices to ensure there's adequate medical supply, research, to ensure that. And we will continue to work with your office to limit those numbers and to ensure that we have the proper medical supply out there.
Well, let's start with this. If our government doesn't start by a reasonable regulation of the production, pharma will continue to ask for more and more and more and more, far beyond what's medically necessary, far beyond what's needed for chronic pain and ordinary uses. So if DEA, the Drug Enforcement Administration, is not in on the program, we're going nowhere with this conversation. And I hope that that changes, and soon. Senator Kennedy and I put it in a bill, and so far we haven't had a response from the DEA that I think is appropriate. May I ask Dr. Gondoltra a question? Is there an antidote to fentanyl?
In your initial statement, you had mentioned that you had heard anecdotal reports where people had required more than 1 dose of naloxone as a reversal for opioids. At this time, that is our That is our FDA-approved option. Naloxone has been used to reverse opioid overdoses. However, long-acting substances like fentanyl may require more than one dose. That's why even after someone has had naloxone administered and they have, been resuscitated, they still require adequate medical supervision. So to answer your question, it's the option we have right now.
And so this is a point I'd like to get to on the scheduling of fentanyl analogs, and we've discussed this in a separate meeting. I am not opposed, Senator Feinstein and others, of putting fentanyl analogs on a Schedule I as they currently are, and as you mentioned, will expire in 51 days. What I worry about, what I'm concerned about, is we do not have a really effective antidote to fentanyl. And I'm worried that what we're putting onto a Schedule I process, which prohibits production in the United States, is going to close out the possibility of research into an antidote for fentanyl, which I think should be underway. It would be, I think, ludicrous for us to believe that fentanyl is going to disappear, even if the import numbers are coming down. What I'm asking you to do, all I'm asking you to do, is in putting these fentanyl analogs on Schedule I, give us some process so that researchers can look for that fentanyl antidote, which could literally save lives today. Naloxone I guess, has some value, but really doesn't have the effective application that could make a difference. Mr. Chester or Ms. Liscombe, if you'd like to respond.
Yes, Senator, thank you very much. I'm proud to say that ONDCP, the Department of Justice, and Health and Human Services have been working throughout the summer on that very balance that you talk about, which is the balance between controlling substances that are dangerous as they come into the United States, but allowing adequate researcher access. And we believe we struck that balance, and we've enjoyed working with the committee on this to ensure that as substances are gathered up that are more than reasonably dangerous and potentially dangerous, that we provide an unprecedented level of researcher access to be able to pull them out of the schedule for research purposes to do two things: to determine their medical merit, as you discussed, maybe the next generation of naloxone, or to determine that they have no active effect on the body or that they're not dangerous and that they should be descheduled. We believe that the work that we've done between both of those departments actually strikes that balance very, very well, with an unprecedented level of researcher access, but at the same time an unprecedented level of control for the substances that are dangerous to Americans.
Let's continue that conversation. That's the balance I'm looking for, too.
Yes, sir, absolutely.
Senator Blackburn.
Thank you, Madam Chairman, and thank you to each of you for being here. I think you can hear the bipartisan frustration in our voices. We have an issue that continues to get worse, not better. In Tennessee, we have seen an increase in our drug-related deaths. We're, 1,837 last year. That was up from 1776. We know from our national law enforcement community that fentanyl-related deaths are increasing. Our TBI director, Roush, has said he is seeing a continued increase. So it is something that we're facing statewide. We seem to have a problem with fentanyl on the streets and with meth in Upper East Tennessee, and we engage regularly, constantly, with law enforcement and healthcare professionals. And this is why we need you all to really collaborate with us in a timely manner to find answers to this. Senator Feinstein and I sat down and talked a little bit yesterday about how drugs and mental illness and how that affects the homeless issue, which they're struggling with in California. Many of our cities are. So we need to move past these discussions. We've been at this for a while, especially with the opioids, and look at what is going to be a coordinated long-term strategy. Look at how we're going to get resources to law enforcement in some of these hardest hit areas around our country. And we've got a Knoxville task force. DOJ has commended them, and we commend them for the good work that they are that they are doing. And when it comes to HHS, what are we going to do to promote treatment for the thousands of addicts, people that are caught up in a revolving door situation with law enforcement? They are incarcerated and they are not receiving the treatment that they need. So, Mr. Chester and Ms. Liscombe, I want to come to you first. Talk about what you're doing to get resources to law enforcement. And Dr. Gandotra, I'd like for you to talk about a little bit about treatment and what you all are changing to make treatment and recovery available for physicians. What are you doing to train doctors? What are you doing to educate pharmacists when it comes to this? As Senator Durbin just said, the number of pills that are in the system, and then being able to achieve that balanced approach, people that need it to get it, but then to get the rest of it out of the system. So, Mr. Chester, to you first, Ms. Liscombe to follow, and then Dr. Gandotra, and please be mindful of the clock.
Yeah, I'll be very quick, Senator. When you talk about resources for law enforcement from the Office of National Drug Control Policy, principally it is the High Intensity Drug Trafficking Areas Program, or the HIDF program, that funds law enforcement task forces at the state level that are state, local, and federal. And that is the principal.
A combined effort.
In a combined effort, absolutely. The thing about the HIDF task forces is that they are unique to the particular area and focused on the particular drug threat in that area, rather than a one over the country solution.
They're given the flexibility necessary.
Absolutely, yes,
okay,
ma'am.
Ms. Liscombe.
Likewise, at DOJ, we have a number of strike forces where we utilize the same methodology in terms of combining resources with local and state law enforcement, specifically like the Appalachian Regional Prescription Opioid Strike Force. Right. They're focused on efforts in the Appalachian region, and while they do have DEA, FBI, and HHS OIG involved, they also very much rely on their local and state partners in order to combat the diversion of opioids in those areas.
Thank you.
SAMHSA is anchored in evidence-based practices, and certainly promoting evidence-based practices through provider education. We have two main initiatives: the provider clinical support system, which implements data-wavered materials into medical school curriculums, as well as provider education for substance use disorder education as a whole within healthcare settings and education. We believe that healthcare settings is certainly the place where we can improve our scope for educating the next level and the next generation of providers.
And how widely utilized are those programs?
50, I believe over 157,000 individuals have been trained through both programs.
Thank you. Yield back.
Yes, Senator Whitehouse.
Thank you very much. Let me start with a question about the Purdue Pharma case. I don't know if either of you guys were involved in that from DOJ, but more than a year ago, in August of 2018, Senator Hassan and I sent a letter to the Department of Justice asking about why the case against Purdue Pharma that was being proposed as a federal criminal indictment out of the Western District of Virginia, once it got to the political side of the Department of Justice, suddenly got turned into a misdemeanor prosecution for a fine that in the context of this litigation is not very significant, and that operated not against Purdue but against a holding company so that Purdue could continue to do business with Medicaid and other federal programs. The fact that Mr. Giuliani was involved at the same time that he's involved with the Department of Justice on other matters adds an extra odor to the disappearance of this prosecution at the political level. And first of all, I'd like to try to get an answer to my darn letter from August of 2018. I don't think that's asking too much. And second, I'd like to know what you know about why that prosecution was made to disappear and turn into a misdemeanor settlement.
And I can look into that letter, Senator. I'm not aware of what the status is, but I will be sure to take that back to my colleagues. I was not involved in that litigation, so I don't have a lot of specifics to share with you, but I can tell you that the department is very actively looking into nationwide manufacturer and distributors of opioids. We recognize the role that many of those companies played, including the executives in those companies, and in contributing to the opioid crisis. And
So you're in the multi-district litigation, right? You're at least a participant in it, if not a litigant.
we have filed a friend of the court letter
Correct.
in that litigation. That's correct.
And what assurance can we have that in your role as a friend of the court in the multi-district litigation, the Department of Justice will actually take a serious position in favor of the plaintiffs when the record so far is that you call in the right lawyer, you go to the political appointees at DOJ, and your case disappears into a misdemeanor against a holding company?
So as a friend of the court, we're not a party to the multi-district litigation. We are simply there to help provide guidance to whether it's the court or the plaintiffs in that case. And while
Which way is the guidance going to go?
I think it depends, Senator, on what the issue is and what help they need. I know that right now we've been involved with helping with depositions of DEA, either current or former employees. We've been assisting in pulling together the ARCOS data that's been requested as part of that litigation. And while
So supporting the discovery phase and the information gathering phase of the effort.
That's correct, Senator.
And when you take a position, will the same people who scotched the Western District of Virginia prosecution be making the decision as to what position the department should take substantively?
I'm not sure what position the department is going to take. I don't know what the issue is going to be, but I can tell you that, and I again reiterate, the department does have open investigations, which I obviously can't comment on, but is very actively looking into this space and trying to find, to hold people accountable for their involvement in creating this crisis.
Well, I hope you do a better job than you did the last time. The last question I have has to do, and this could go to whichever one, this is more of a technical question, but as you've heard today, there is broad bipartisan support for scheduling fentanyl as a unlawful drug. However, and all of you seem to agree with that, however, when we go to HHS, this administration says, no, we shouldn't do that because the chemistry in this question is very complicated. And if you ban fentanyl analogs, you will likely get into potentially banning drugs that could actually help with addiction or with, response to an overdose. So it seems to me that the most important thing that you all could do is get the administration aligned behind a program for how we schedule fentanyl without banging into the objections from HHS. Perhaps, Mr. Chester, you can lead with that because I think you're probably trying to coordinate this effort.
Yes, Senator, and we have been. And we have been coordinating between HHS and its departments, NIDA, FDA, CDC, NIH.
Do you have a result yet?
Excuse me, sir?
Is there a common position yet?
Yes, sir, there is. And the common position was captured and transmitted to the committee in September, which, as I discussed earlier, is the balance between gathering. And when we talk about fentanyl, I do want to be clear. I do want to be clear. What we're talking about is fentanyl analogs, which are additions or substitutions to the fentanyl skeleton. So that's how it's defined, that are reasonably assumed to be active in the body based upon a structure-activity relationship, right? So as these substances come in, they're variations of fentanyl, they're captured. The other side of that, and this is the HHS portion, is to be able to have an unprecedented level of access, to be able to access those substances, be able to do research on them, determine what their actual activity is, and then determine if there's any medical merit. And that's what we've been able to do between the Department of Health and Human Services and the Department of Justice, bringing them together to get an agreement that we have struck the right balance between control and access. And that's what we've presented to the committee.
Okay, well, my time's expired. More to follow.
Senator Cornyn.
Dr. Gandrotra, we talk about opioids. That includes, that's an umbrella term, correct? Includes prescription drugs, heroin, fentanyl. Is that the universe of what we consider to be opioids?
Certainly, it would include all of those synthetic and natural, opium, heroin, all the way through to prescription drugs as well.
And is in your experience as an addiction specialist, when people can't get prescription drugs, do they opt then for a cheaper alternative like heroin frequently?
A subset of individuals do. Not everyone would, but certainly a subset would.
And I think the figure I saw last year, there were about 15,000 heroin-related deaths, although I know the numbers get kind of murky because frequently, as several of you have mentioned, you have a cocktail of a variety of drugs, sometimes mixed together, which is deadly, obviously. You mentioned naloxone, which is something that's administered by first responders and others when somebody is suffering a drug overdose. I think you mentioned there were 14,000 roughly applications of that drug last year successfully, but that just saves the person's life from the overdose at that moment. That does not cure the addiction, correct?
Correct. We believe at SAMHSA, and most addiction professionals would believe, that treatment has to continue for an extended period of time. Simply one intervention won't be effective, whether it be reversing the overdose. And I would highlight that naloxone administration is evidence-based practice. Certainly it is something that we promote as a wonderful option for reversing opioid overdoses.
It's certainly been a lifesaver, but my point is, and you just made it as well, that the person remains addicted and needs additional treatment and help, correct?
Correct. Treatment should extend on the full spectrum from if a person requires detox, residential, outpatient. Right. Treatment has to continue. We know that when patients stay in treatment, we have better outcomes.
How about other drug? Do they get moved to other drugs like methadone or something like similar?
So thank you for bringing that up. Medication-assisted treatment is the gold standard for opioid use disorder, whether it be methadone, buprenorphine, or naltrexone. All three are FDA-approved medication-assisted treatment that have been found to decrease overdose, improve social capital, in particular employment, criminal justice involvement, homelessness, and engage in other treatment-seeking behaviors, reducing HIV spread. So certainly getting patients in treatment is our goal.
You mentioned Chairman Ernst, and you discussed mental health issues. Do you see substance abusers who are people suffering from a mental health crisis who seek to self-medicate? Is that a phenomenon that you see?
That, again, would be one subset of individuals. Certainly, the substance use disorder and mental illness are interactive, reinforcing. Typically, when one gets worse, adherence to the other treatment gets worse as well. But when one gets better and effectively treated, it can provide a conduit for the other. Certainly, there's a subset of individuals that have co-occurring for both mental illness and substance use disorders, and others that don't as well.
Mr. McDermott, the one source of opioids we really haven't talked that much about so far is the Mexican drug cartels and the border, something that your agency specializes in combating. I know there's a lot of outrage, justified outrage, at pharmaceutical manufacturers that over manufacture and doctors who overprescribe prescription opioids, but a substantial amount of opioids comes across our southern border from the Mexican drug cartels, correct?
Correct.
And the fentanyl transits through Mexico from China. Maybe not all of it, but a substantial amount of it, correct?
Correct.
And so if we really want to get serious about combating the opioid crisis in America, we have to get serious about border security and intervening or interdicting, I should say, those drugs before the cartels are able to smuggle them into the United States. Do you agree?
Correct.
Yeah. And of course, the proceeds of these illegal drugs that the cartels manufacture are used to subsidize their other illicit activities like human trafficking. Is that an accurate statement in your experience?
That's accurate.
Okay. Madam Chairman, I see my time has run out.
Senator Coons.
Thank you, Madam Chairman. Thank you to the witnesses before us today. One of the things I wish the average American had the time to hear is the broad bipartisanship of the approach of the members of this panel to working with the administration on trying to address our nation's opioid crisis. 48,000 Americans died of overdoses last year. That has ravaged every state, every community, at every level. Any senator who's doing their job has been to funerals, has been to parent groups, has engaged with their public health community, and has tried their best to tackle this. And you have heard broadly shared frustration about how slow some processes are moving, like scheduling fentanyl, and how much we seem to still have failed to grasp the depths and breadths of this crisis and acted in a corresponding way. Mr. McDermott, you're the Assistant Administrator for Diversion Control of the DEA, is that correct?
That's correct.
And I am grateful for what the DEA does in Delaware and across the country. But we lost 400 people to overdoses last year. That was a 15% increase over the year before that, an increase over the year before that, an increase over the year before that. And in a bipartisan effort to try and find something more that needs to be done, I've worked with Senator Cory Gardner of Colorado on a simple issue, knowing where the drugs are going. And as you've heard from several of my colleagues, Senator Durbin forcefully pointed out that we've had a system that now for years sends literally millions of opioids to towns that have tiny little populations or pharmacies, and interdicting that diversion would strike me as a pressing goal. We live in a world where you can order a pizza or a package from Amazon and know in real time by text or calls or emails, if you want them, exactly where your package is and when it's going to arrive. And we've worked with DEA now for months and months to try and get consensus on whether or not the DEA wants real-time knowledge of where massive deliveries of opioids that are likely to be diverted are happening. All of us are familiar with the story of a small town in West Virginia that ended up with millions and millions of doses for a town that had just a few thousand residents. So if I could, Mr. McDermott, does the DEA have the ability now to track shipments of opioids as they move from the manufacturer to the distributor to the pharmacy that placed the order? Do you have the ability to monitor that in real time now?
Senator, we do. We enhanced our ARCOS data, so we've done that. We also, as part of the Support Act, we had the SOARs. We've been in October of 23rd of this year, we have that coming in. But to answer your question about real-time data, a monthly would be better at this point right now. We're still in.
So it's not real time now, to answer my question. It's not monthly now. When do you get data about how large a shipment has made to a particular town or pharmacy?
By statute, we receive 30% of the manufacturer and distributors, 30% on a monthly basis, 70% on a quarterly basis, and that's by statute.
So by statute, the vast majority of the data that if I were in your shoes as a law enforcement officer, I'd want, you get months after the deliveries.
That's correct.
Okay, so Senator Gardner and I have introduced a bill, the Suspicious Order Identification Act, that would help you collect and analyze that data in real time to ensure that you've got knowledge you can act on, that state law enforcement can act on, that pharmacies can act on when we see different manufacturers and different distributors all homing in on one town and delivering millions and millions of doses. Last year, enough opioids were shipped to my little state of Delaware to allow every single resident to have 45 pills a year. And I bet you the vast majority of Delawareans weren't on opioids last year. But 400 took enough to die. One of the issues this has been focused on is 3/4 of them died because of a mixture with fentanyl. And I commend both our efforts to try and accelerate the scheduling of fentanyl and the steps that China has taken, but there is so much more we have to do. Dr. Gendotra, let me ask you about the ways in which we can and should be innovative around developing new methodologies for treating pain and addiction. I've also introduced with Senator Gardner of Colorado the EFFORT Act, which would support and fund critical research into the science behind opioid addiction. It's already passed out of the House. It was unanimously voted out of the Senate Commerce Committee. I hope we will see a full Senate vote on it soon. Can you speak to which aspects of the opioid crisis would benefit the most from additional research? And before you answer, I'll mention we all just learned that on a bipartisan basis, there will be more funding for brain research for the NIH and more funding for the NSF this coming year. Where do you think we could make the biggest impact on opioid addiction with more research?
Certainly anchored in evidence, the research supports all aspects. Prevention efforts certainly have yielded fruit. Treatment with the evidence-based practices that we already have. Expanding MAT is probably one of the biggest ones we would promote, as well as recovery services, because treatment isn't just in the setting, in the clinic, but also recovery communities. That's where the evidence lies. That's where I would expect the greatest fruit to be yielded.
Well, I'm also pleased that the outcome, it seems now that the outcome of our appropriations process will be that ONDCP will receive it. The Office of National Drug Control Policy will have a modest but I think deserved increase in the HIDA funding and the drug-free communities funding. Folks, this is a genuine national crisis that demands all hands on deck and all of us engaged in finding the best ways we can to deliver resources for research, for law enforcement, and for coordination at the federal and state level. Thank you, Madam Chair.
Senator Hawley.
Thank you, Madam Chair. I wanted to start by saying that for the state of Missouri, this is a crisis that has been truly devastating. Missouri's life expectancy in the state as a whole has actually been declining now for years on end because of the surge in drug overdoses, because of the surge in deaths of despair, often linked to opioid addiction and other drug addiction. It is taking an enormous toll, of course, around the country, but Missouri is unfortunately in many ways ground zero for this epidemic. So thank you all for being here. Thank you for the work that you're doing. Ms. Liscombe, let me start with you. As Attorney General of the state of Missouri, I brought suit against major opioid manufacturers. We were the, I think, second or third state to do so. It's very early on. This has been 2.5 years ago, getting close to 3 years ago now. I understand that the Eastern District of New York has now started its own criminal probe of opioid makers and distributors. I'm wondering if you can give us some sense about the scope or the stage of that investigation, anything you might know about where it stands.
Unfortunately, I can't comment on open investigations, but I can point you to two public indictments of manufacturer and distributor executives as of late. One was some executives of Miami Lucan, and the other was of Rochester Drug Corporation, where we have made a point of holding the executives who are in charge of these companies who have helped contribute to the crisis responsible.
Yeah, I think that's very important to do. And speaking of executives, is it possible that individual executives at some of these companies, these major distributors, makers, may be investigated and charged? Is that potential?
We will obviously go where the evidence takes us, but that is always a possibility.
Good. Well, I'm glad to hear that. I hope that federal prosecutors will look very closely at that, because I do think that if we are going to be charging opioid and heroin dealers and putting them in prison, and we absolutely should, but that accountability has got to go all the way up the supply chain. And I know from our own investigation in the state of Missouri, the outright deception of many of these pharmaceutical companies. They knew that opioids were addictive. They knew what the side effects were. They knew the data did not support prescription in the mass numbers that they were being prescribed, and yet they deliberately misled the public, sometimes in particular doctors and veterans and other at-risk communities deliberately did so over a number of years and made literally billions of dollars in it, and there has got to be accountability in the law for this. Let me come back to the question of drug smuggling. Mr. McDermott, maybe I'll address this to you. In the state of Missouri now, the supply of prescription opioids, the black market supply, I should say, is being ratcheted down, which is generally a positive thing. It's a very positive thing. However, what we're seeing is drug addiction continues to surge in the state, and in the wake of prescription opioids, we're seeing fentanyl, black market fentanyl, as we've been talking about, and then also methamphetamine. Now, those products are not produced in the state of Missouri, and methamphetamine is not widely produced in the state of Missouri. It's produced in Mexico, and it comes across the southern border. And it is no exaggeration to say in Missouri, every single one of our counties, 114, every single one of them is awash in these illegal drugs. And I mean awash in them. You cannot go into a school in my state and not find these illegal drugs with a snap of the finger. So tell me about what our latest efforts are on the border. How are we doing in interdicting these drugs? What more do you need from Congress? Because this is truly it's a crisis for my state.
Senator, I was the ASAC in Missouri before I went to headquarters, left, came back, and so forth. So I totally agree with you 100%. I can tell you that we're working with CBP. We have some of the highest seizures right now in the United States on methamphetamine. And I can tell you the men and women of the St. Louis division work every day to ensure the safety and well-being of that state. And I can tell you have some great professionals there. And actually, one of the best supervisors I had went right down to your area. So and we are adding additional bodies, as well as when I was the ASAC there, we were able to get additional special agents assigned to the St. Louis division. So I believe that we're doing everything we possible to work with our state and local counterparts, as well as Department of Justice, and you have some excellent, you have an excellent U.S. attorney in your state.
What more do we need to do specifically on the border, however? And Ms. Liscombe, feel free to chime in here. You mentioned this in your statement. I mean, what has to happen to see the flow of these drugs? I mean, it's one thing, we prefer not to have to deal with it in the state, right? I prefer these drugs not to come to the state to begin with, and they are pouring into the state. In Springfield, Missouri, for instance, we've had record numbers of overdoses just in a 2-month period, more overdoses in a 2-month period from what looks to be fentanyl and potentially methamphetamine than we had all of last year. That's just unbelievable. So the drugs are just pouring in. What do we need to do to stop the flow across the border?
And Senator, you're absolutely correct. The drugs that are coming from the Mexican cartels, whether they be methamphetamine, fentanyl, or analogs, are devastating this country. I would just refer you back to the permanent class-wide scheduling of fentanyl analogs. That is our #1 priority right now. We have 51 days left, and we very much need Congress to act on this one point. And so I think that's the #1 request at this point.
Thank you very much. Thank you, Madam Chair.
Senator Hirono.
Thank you. I know that we're here talking about opioid issues, but as mentioned by Senator Hawley and also Senator Ernst, that other states have other problems. In Hawaii, it's mainly still meth. So I'd like to ask you, well, let me give you a little bit of data on Hawaii. The Hawaii High-Intensity Drug Trafficking Area's 2019 threat assessment identifies meth, not opioids, as posing the greatest drug threat to the Hawaii region. Between 2012 and 2018, the number of people who died from meth overdoses in Hawaii increased by over 250%. And over 70% of drug-related deaths in Hawaii are the result of meth. And the meth problem is not isolated to Hawaii. Data from the Centers for Disease Control and Prevention shows that meth overdose deaths nationwide increased fourfold between 2012 and 2016. What resources are your organizations, this is for the whole panel, are your organizations committing to address the increased use of meth in states like Hawaii, and obviously it's in Missouri, it's in Iowa, and what additional resources do you need?
Senator, I can start and then we can work our way down. At the beginning of this year, Director Carroll had spent so much time traveling around the country and had heard from so many members of Congress and realized that we had put so much effort into the opioid crisis, and rightly so, but that we'd learned a lot and we had developed a lot of architecture, and we should apply that to methamphetamine as well. And so we've been on a deliberate effort now to gather the information, bring together the interagency, and come up with some tangible solutions that we can do about methamphetamine. I had a good conversation with the U.S. Attorney from Hawaii, talking specifically about methamphetamine, where he believes it's coming from and what the patterns are as well. And it's not only the problem of the drug itself, but it's the associated criminality around the methamphetamine trafficking that's deeply affecting Hawaii. And so we're working to find tangible solutions, whether that is using grant money that has specifically been for opioids and expanding that to methamphetamine as well. As was mentioned earlier, the Drug-Free Communities Prevention Program and the HIDA programs are all ways that we can understand that this is a clear problem across the country. It's not geographically located, and that we can take a lot of the stuff that we've learned from the opioid crisis and apply it to methamphetamine as well. And you'll.
Any of the other panelists want to add?
Thank you, Senator. I think that I echo what Mr. Chester said with respect to the grants. There are many grants out there that are focused on the opioid crisis, as they should be, but we have been hearing increasingly that there is a need to get money to help address methamphetamine, which I also have spoken with the U.S. Attorney there and recognize what a huge issue it is in your district. I just cannot point enough to what is happening with the Mexican cartels, and they have been for several years and continue to produce methamphetamine. It is very profitable and easy for them to make. There's a huge profit margin, and the purity rates that we're seeing as of late are through the roof and close to 100% purity. So it is an epidemic. It's something that we are continuing to work with, and I think DEA can speak to some of the programs, but I know that we are looking at domestic trafficking routes, and we are looking at how we can best attack the cartels that are bringing this into the country.
Do you know how most of the meth coming into Hawaii are coming in through the mail? Is it through our ports? Do you know?
What I have heard from speaking with the U.S. Attorney there is it's coming in through both routes, and they're doing what they can to address it. My understanding is that there's very little opioids in Hawaii, and that it is primarily meth.
Relatively speaking.
Yes, compared to some of these other districts. And so we are working on ways to help with that office in terms of stopping the flow of methamphetamine into that state.
So have any of you come up with something very specific with regard to stopping the meth coming into Hawaii, and also what kind of treatment options or prevention options there are for a state like Hawaii? Anything specific?
I think DEA could speak to the great work that they're doing with the government of Mexico to identify some of the labs down there.
So currently, on two things, to answer one of your previous questions, we have, these cartels are polydrugs. So the administration in 2018 provided us with DEA with funding for over 400 task force officers from state and locals that know the area and know what's happening on the street level. So we've been able to implement that. It was for the opioid crisis. However, due to the fact that it's polydrug, they are working cases that now are methamphetamine as well. So we've seen a surge in the task force positions, as well as we have 11 offices in Mexico right now. Our primary office is in Mexico City, and we were working with the Mexican government on a day-to-day basis to take out these methamphetamine labs. We're working with them on record seizures, I said, in the United States, and also we're looking at high-value targets to be brought back to the United States and face justice here.
My time is up, but I'd like to submit a question regarding prevention, because it's one thing to keep all these drugs from coming into our country, but it's another once they get here, and what are we doing to prevent the usage of these drugs, especially among young people? Thank you.
Senator Kennedy.
Mr. McDermott, it seems to me we've got three problems here. People in China are addicting our people in America. People in America, or rather people in Mexico, are addicting the American people. And the United States government is addicting the American people. Senator Durbin talked to you about the current quota being 8 billion doses of opioids a year. Is that right?
By his math, sir, yes.
That's 25 Vicodin tablets for every man, woman, and child in America. Now, if I take 25 Vicodin over 2 weeks, I'm going to get addicted, aren't I?
Probably, sir.
Yeah. So we can agree then that the 8 billion's too high, right?
Sir, I would not agree on that. What I can say is that...
Why not?
Because it depends on the medical use, sir.
I understand. We know what the medical use is. It's 25 Vicodin tablets for every man, woman, and child in America. You don't think that's too high?
Sir, our quota is based on what we think is necessary for the medical use, as well as research, as well as exportation.
And you think you think we need every one of those Vicodin tablets?
Sir, we're trying to do a balanced approach, but what I can tell you is I assure you I will work with your office and with Mr. Durbin's to ensure that we're providing adequate.
Mr. McDermott, I'm not trying to be rude, but you reach a point where patience ceases to be a virtue. You're telling me we need 8 billion, that's like 9 zeros, doses of opioids per year for the American people. 25 for Vicodin tablets, let's say, for every man, woman, and child. That's your testimony. We need every single one of them.
Sir, I said what the quota that we have is appropriate for what we believe for the United States.
And so you think that's what we need?
The quota we believe is appropriate, balanced for what I've discussed.
Okay. I think you're saying yes. Is that right?
Sir,
I don't speak BS. Okay? You're saying yes, right?
Sir, we believe the quota is appropriate.
Okay. All right, let me ask you this. You get information about what pharmacists are prescribing, right? Quarterly and monthly in some cases?
No, we get information on a quarterly and monthly basis what the manufacturer and distributors are distributing to the pharmacies.
I think we just said the same thing. So if you see that a pharmacy in Bucksnort, USA, population 1,500, just prescribed 7,000 Vicodin tablets last month, that kind of tells you something, doesn't it? That's too many, right? Can we agree? They don't need, I mean, we can agree that's too many, right?
Sir, if we had that data, which is what you're describing is the PDMP data, we have the data that goes to the pharmacy. We do not have the data that goes out.
Well, why don't you go get it?
Sir, we don't have that. We'd have to get that from the state, and if we could ask for your assistance, we need that. That would be a game changer.
Well, it doesn't seem to me that this is real complicated. If a pharmacist is writing scripts for 5,000 Vicodin tablets in Bucksnort when there are only 1,500 people, we got a problem. Duh.
I agree with you.
And so you send somebody in and you say, Mr. Pharmacist, who in God's name is prescribing all this? And then you stop it. And if you don't stop it, you punish them the rest of their natural lives.
I would agree with you 100%.
So why don't you do it?
Because we don't have that data.
You don't have the data. You don't have the data. Doc, let me ask you something. Now look your record up. You're a smart man. Yale, Howard. You're telling me you've got to go out and educate doctors and pharmacists that if you take too many Vicodin tablets, you'll get addicted? You talked about evidence-based practices. You telling me that the average doctor in America doesn't understand that if you give somebody a 6-month supply of Vicodin, they're going to get addicted? We got to educate them for that?
What we're talking about, Senator, is enhancing medical school curriculum, provider curriculum, so that it is addressed.
Doc, I barely got through the part where you cut up the frog in biology. And I know that if you give somebody a 6-month supply of Vicodin, they're going to get addicted. Why don't we do something to the doctors that are doing this? They don't need evidence-based training. They've been to medical school. I'm over.
Senator Blumenthal.
Thank you, Madam Chair. I think as you have sensed, there is impatience and anger and even fury about this opioid crisis. And with all due respect, I know that you all are the messengers. You're not the policymakers, and you have to take back our message to you. And I think you can sense that it is one of frustration, to say the least. And as my colleagues have expressed, I don't think it's good enough to say as you have, Mr. McDermott, will work with you, because that's what agencies have been saying to us, and maybe partly the fault is the United States Congress, and if so, you should tell us. But this crisis has existed for some time. It's not suddenly reared its head. Going back to years ago, Connecticut's rate of addiction was rising, and so was its rates of death due to overdose. In 2018, it was 1,017 overdose deaths, and that number is expected to rise this year. Between 2012 and 2018, there was a 221% increase in opioid-related deaths. That's in Connecticut alone. So I think that there has to be an effort to hold accountable not only the Mexicans and the Chinese, but the manufacturers and distributors in this country. And Senator Kennedy raises a valid point. I've raised it numerous times since my 4 children all had athletic injuries, and they were prescribed 30 days worth of opioids. And the first thing my wife and I did was tell them they weren't getting any of it. And I recently had shoulder cuff, rotator cuff surgery, and I was prescribed, I think, about the same length of opioids, and I didn't even bother filling the prescription. And yet there are now medical courses in medical schools on pain management. So the medical profession is recognizing its responsibility. And I think that the manufacturers and distributors need to be held accountable too. And in terms of the consciousness about this issue, I know, Ms. Liscum, you have prosecuted Mexican and Guatemalan politicians, corrupt politicians who took bribes from cartels and major cartel heads. In your view, has the level of corruption diminished over recent years?
I think depending on the country that you're looking at, there are different levels of corruption. And one of the reasons that I spend a great deal of time working on those types of cases is that obviously when there's corruption, it allows the cartel to operate in that country sort of carte blanche. But you've seen no diminishment of the levels of corruption in those countries. I personally have not seen a diminishment, but I have not been as actively involved in those investigations in my current role. How do most of these cartels ship their drugs into this country? I can speak from my experience. I have had the opportunity to sit down with numerous members of, or I should say former members of the Sinaloa cartel who are now cooperating witnesses, who've described routes such as tunnels that they spend $1 million to build under the border, to using whether it's a passenger vehicle or a truck that has hidden compartments in it to bring drugs in through lawful ports of entry. I've personally prosecuted cases in California where what's called a ponga boat, which is basically a fishing boat that has an outboard motor, is used to traffic drugs through a maritime method along the Southern California coastline. I can say that the cartels will do anything and everything that they can to get drugs into this country and make as much profit as possible. A wall is not likely to stop them, correct? I don't know. I think that they utilize every method that is possible for them to get the drugs into the country. But so far, you've mentioned tunnels, ports of entry, water routes. None of those would be prevented by building a wall. And I'm not going to press you on this point because I recognize the limits of your appearance here, but I do appreciate your testimony and all of those who've been here today. Thanks very much.
Senator Tillis.
Thank you, Madam Chair. Thank you all for being here. I didn't plan on asking this question, but I think I will start with you, Ms. Liscum. When we think about the wall, which many people describe as just being this monolithic structure, a fence, or something along those lines, It's my understanding that we're trying to work on tunnel detection capabilities, technology, particularly over in California and other parts in the Southwest. I believe that we're talking about updating our legal ports of entry with scanning technology that could get to 100% scan of vehicles, and then also building structures. We've also had discussions about funding Coast Guard more so that they can better beef up their interdiction efforts and secure the border. Do you believe that if we were focusing on those, identifying tunnels for illicit trade and human trafficking, drug trafficking, having 100% scan at the legal ports of entries, that concept of a wall would probably have a beneficial impact on drug interdiction?
I think the department could use every possible tool available to combat the drugs coming into this country, and so I think all of the tools that you mentioned would be beneficial in helping to stem the flow.
Yeah, me too. Thank you. Mr. McDermott, happy holidays. I actually want to say something that I think is positive that's coming out of the DEA, and it has to do with some of the emphasis on potentially prescribing Schedule III opioids over Schedule II because they appear to be less addictive, and I appreciate you all's efforts on that behalf. I am kind of curious with the data coming out of your agency. I'm not seeing it necessarily the same focus, at least at this point, with the CDC and other agencies within government. Do we have any idea when they will actually catch up and with some of the policies that you guys have already been moving and trying to provide data that the prescribers? I share Senator Kennedy's concerns with the prescriptions, but it does look like you are trying to emphasize potentially they are opioids, but potentially less addictive and less likely to provide a gateway. So first, thank you for that work, but what about the rest of government? What's our progress there to really try to emphasize these less addictive drugs?
Well, what I could say is we're working on a daily basis with HHS and FDA and CDC and DOJ and ONDCP as a whole of body government. And I can tell you that what we do is to ensure what's best for the U.S. citizens. And we're working on that. And I hear Senator Kennedy and I hear Senator Durbin, and I assure them we will continue to work on what they've asked us to do.
And I think we need all the agencies to catch up. I think y'all have done some good work there, and you should be commended for it. I don't know who to ask this question. It may be the doctor in the house, but I have it's my understanding, at least back when I was Speaker of the House and we were trying to work on this as a matter of state policy, and North Carolina is one of the states that have implemented policies to reduce the prescribing opioids or minimizing the amount that they're prescribed with some sort of oversight and check back. But it's my understanding a few years ago that one of the leading causes of suicide in this country are people who are experiencing chronic pain conditions. Is that still accurate?
It is a major cause. I wouldn't say it's the leading cause, but certainly it's.
So one of the things we're trying to balance is if it's the only medication that has efficacy around these things that are chronic pain, it's one of the reasons why we prescribe it. Would you agree with that?
Well, I'd say it's a thoughtful perspective that individuals with chronic pain, in particular, they may develop opioid dependence, but not the other behaviors of substance use disorder. The CDC has issued guidelines in 2016, and I believe they'll be in process of revising those prescribing guidelines. And when it comes to provider education, I'd like to provide just a little bit of clarity. SAMHSA's goal is to provide improvement in those individuals who have substance use disorder and mental illness, and we try to implement evidence-based practices when it comes to our medical school curriculum for treating substance use disorder and opioid use disorder, not necessarily limited just to prescribing practices.
Thank you. Mr. McDermott, you, in response to one of Senator Kennedy's questions, you said you'd love to get the data from the state that you don't have today. It's not like you can just call up the state health department and say, we want this information. You need some sort of statutory support to do that. Is that correct?
That's correct.
Okay. And what does that look like in terms of what we need to implement?
So what I would ask is that you make the states have to provide us this information.
So mandate that the information that you would like to have, because it could actually provide the kind of insight that Senator Kennedy would like for you to have, but absent congressional action, you don't have that.
We do not. We have to go on a state-to-state basis. And as I said, I was a SAC in Colorado, and we have to sue the states to get that information.
Thank you.
Senator Leahy.
Thank you. And Doctor, you mentioned evidence-based prevention. I agree with you. We have to have that. We have to have treatment. We have to have recovery programs, enforcement actions that actually do things. And as Vice Chairman of the Senate Appropriations Committee, the bill that was filed late last night, I've tried to prioritize these issues. In the budget package, we've got $1.3 billion as of last night in the fight against the opioid epidemic, $110 million for rural communities opioids response program, $500 million for targeted research on opioid addiction, pain management, and so on, $31.9 million for pregnant and postpartum women with opioid abuse disorders, $89 million for medication-assisted treatment for prescription drug and opioid addiction. So I think that money is going to be a help. And if any of you disagree with having that money in there, please say so, because we start voting this afternoon on my on what I have in there. And I thank the House members and senators of both parties who worked with me on that. Now, we've done a lot of progress in my state of Vermont. We have one of the lower percentage of opioid addiction, but we still have problems. The University of Vermont, federal grant, set up a rural center of excellence, which is great also in the Burlington area. But then we have those who are in hard-hit rural areas. We don't want to see them drive 2 weeks or 2 hours each week for a treatment. Should healthcare professionals be able to describe buprenorphine for addiction just like they do other medication? I'm thinking how we reach in these rural areas.
Certainly, SAMHSA is integral as the final arbiter for the X waiver for buprenorphine products to treat opioid use disorder. We would certainly support any further expansion of rural treatment centers. Vermont, I would comment, was one of the first to implement the hub and spoke model, where individuals would have initially get treatment at a specialty site, a hub, and then continue treatment in the community at a spoke center. So certainly we would want to not only do that, but also improve our telehealth options as well.
I appreciate that, because that hub and spoke has brought our numbers down considerably below what some of the surrounding areas in the states have. Let's work together on this, because we can talk about it and agree on it here, but we've got to make sure it happens. Now, the Chinese government took some steps to prohibit fentanyl coming out. Are the targeted sanctions that have been put in place making a difference in terms of the volume of fentanyl that's being shipped to North America?
Senator, I can start and then turn it over to Justice if they have something to add. We have seen a decrease in direct from China shipments of fentanyl analogs, and synthetic opioids into the United States, and that's a positive step in the right direction. The two things that we do have to watch are indirect shipments from China into the United States, which means it comes from another country like Canada or a European country that we're not watching as closely. And the second thing is an increase in the production of fentanyl in Mexico and its trafficking across the southwest border, along with other plant-based drugs. Those are the two things that we're placing a great deal of emphasis on. So while China's actions have had an effect, we need to make sure that they contribute to actually helping to solve the problem.
I agree with you. Excuse me. And Ms. Liskman, you mentioned the importance of anti-heroin task force grants in your written testimony. Well, the administration's 2020 budget zeroed out all funding for the anti-heroin task force grants. They had been appropriated $35 million FY20. I know in our state, the state drug task force uses that. If these are important, why the White House not similarly consider these grants critical to efforts combating our opioid epidemic? Why is it zeroed out?
And Senator, I'm actually not familiar with those figures, but I can tell you that we have, as I've mentioned a couple of them, some tremendous task forces and initiatives at DOJ that have come out over the past couple of years and are actually working, in our view, to help stem the tide on this epidemic. So, again, I'm not familiar with that specific grant budget, but I can tell you that we are trying to put our resources where we are actually seeing results.
Well, I will submit further follow-up questions on that because many of us, Republicans and Democrats, want to keep that money in the appropriations bills. We can talk about it here in generality, but somewhere the money has to come. And when it's not in the president's budget, oftentimes we do add it in, notwithstanding that, but it is more difficult. Thank you, Madam Chair.
Senator Kennedy has asked for an additional 30 seconds.
Yes, ma'am. Mr. McDermott, I know you're new. I'd like you to write me a letter explaining to me in English why every man, woman, and child in America needs 25 doses of opioids every year. And doctor, let me say to you, I know you work hard at what you do. I have two brothers who are physicians, but doctors need to police themselves. You're not going to convince me that someone smart enough to go to medical school doesn't understand that if they give someone a 6-month supply of Vicodin, they're going to get addicted. And the doctors need to police themselves.
Okay, thank you, Senator Kennedy. At this time, we'll release our first panel for the record, and as we are setting up for the second panel, I will go ahead and read the bios of our second panel. I want to thank our witnesses for being here today. Thank you very much. Okay, on our second panel, we have Dr. Bradley Stein, Mr. Patrick Kelly, Dr. Rana Hauser, and Ms. Sue Tao. And Dr. Bradley Stein is a senior physician policy researcher for RAND Corporation. Dr. Stein is a practicing child and adolescent psychiatrist and senior physician policy researcher at the RAND Corporation and adjunct associate professor of psychiatry at the University of Pittsburgh. Mr. Patrick Kelly, as HDA's Executive Vice President of Government Affairs. Mr. Kelly oversees all HDA's state and federal legislative, regulatory, and political activities. And then Dr. Rana Hauser. Dr. Hauser is the Vice President of Policy and Government Affairs, Operations for the National Community Pharmacists Association. And then Ms. Sue Tao, is that correct?
It's Thaw.
Thaw. Ms. Sue Thaw, for over 25 years, Ms. Thaw has been a private consultant specializing in policy issues related to substance abuse prevention and treatment. And to our witnesses on our second panel, I am going to have to ask you to hold your statements to 1 minute, if at all possible. We will submit your entire statement for the record, and then we will proceed with questioning after that. So if you can abbreviate as much as possible. We do have votes that have been called, so if you could quickly move through your statements, that would be very helpful. Dr. Stein, let's start with you, please.
Good morning, Chairwoman, Ranking Member Feinstein, and distinguished members of the committee. As the Chairwoman mentioned, in addition to my research, I'm a practicing child psychiatrist in Western Pennsylvania, and many of the children I treat are children of the crisis, whose parents, siblings, aunts, and uncles have been affected. My clinical work has opened my eyes to how the opioid crisis involves multiple systems. Now, many of our policies focus on opioid analgesics and treatment, but many of the affected families have touched multiple systems. Parents on probation, involvement in child welfare, public housing. And these systems interact in very complicated ways. And I think understanding these interactions and the potential unintended consequences is essential if we are to confront this crisis successfully. We've made great strides in curbing clinically questionable prescribing and availability of opioid pain pills, but some of these efforts have had unintended consequences. For example, some chronic pain patients are being tapered off opioids too quickly, and other individuals have trouble finding a new doctor when theirs retires. We need to both focus on continuing to decrease opioids, but at the same time making sure these individuals have access to better pain management as well as treatment.
Thank you, Dr. Stein. Mr. Kelly.
Good morning, Chairman Ernst, Ranking Member Feinstein, Senator Durbin. I think that's it for the rest of the committee. Thank you for the opportunity to discuss forward-looking solutions to address the opioid crisis in the United States. For the record, distributors do not manufacture, prescribe, dispense, or drive demand for medicines. Instead, our industry's primary mission is to operate the safest and most secure and efficient supply chain in the world. In this effort, pharmaceutical distributors work closely with our supply chain partners and with entities that regulate our industry, most notably the Drug Enforcement Administration and the Food and Drug Administration and all state regulatory agencies. In order to handle controlled substances, every legitimate entity in the pharmaceutical supply chain must be properly licensed and have a valid DEA registration. We look forward to working with the committee as you move forward with forward-looking solutions to address this opioid epidemic, and we look forward to your questions.
Dr. Hauser.
Hi, good afternoon, Chairwoman Ernst, Ranking Member Feinstein, and members of the committee. NCPA represents America's community pharmacists, including nearly 22,000 independent community pharmacies. NCPA members participate in numerous initiatives to appropriately dispense and dispose of controlled substances and to identify possible overutilization. Examples include evaluating prescriptions to attempt to detect forgeries, adopting electronic prescribing, which has helped to eliminate forgery efforts, taking part in Dispose My Meds, which has more than 2,100 participating sites across the country, utilizing Allied Against Opioid Abuse's Pharmacist Toolkit, and advocating for greater pharmacist access to naloxone. And I will summarize my recommendations. I think continued dialogue with all supply chain stakeholders and continued healthcare provider resources are important. Enhanced integration and data sharing, including prescriber systems. Updated DEA pharmacist manual. It has not been updated since 2010, and I would encourage the DEA to do so. Advancing the role of the pharmacist in medication-assisted treatment. Recognizing the pharmacist as a Medicare provider to furnish opioid use disorder services. Expanding workable disposal options, and improve supply chain reporting to ARCOS. Thank you.
Thank you very much. Ms. Thau.
Thank you, Chairman Ernst, Ranking Member Feinstein, other distinguished members of the committee. To stem the tide of the opioid epidemic, more emphasis really needs to be focused on prevention to stop misuse before it ever starts, which is really the most cost-effective way to deal with the epidemic. The Drug-Free Communities program in ONDCP has achieved major reductions in opioid misuse through the implementation of Catecus Model for Community Change that includes 12 required sectors being actively involved and also spans the supply and demand split. We train people to implement 7 strategies for community change. These basically reinforce each other. They include everything from raising awareness through changing policies, practices, and procedures, providing support, building skills, and changing the physical design of the community. In communities that have undertaken these types of approaches, they've seen dramatic reductions in youth substance use and other metrics. And to us, the keys to success that can be transferred from the DFC program to mitigate the opioid epidemic are building and maintaining multi-sector capacity, providing intensive technical assistance and training, ensuring that prevention is a major focus in breaking down silos across supply and demand reduction. Thank you.
Very good. Thank you so much. And I'll yield my time right now. Senator Feinstein, if you want to have some brief questions for our second panel.
I actually have no questions, but thank you for coming. Thank you.
Okay, Senator Durbin.
I just basically want to ask a question of the distribution chain and the folks representing the independent pharmacies here. I used an example here at the outset of a county with 4,300 people that received 2.7 million opioids. One pharmacy received it.
Good question.
There is a process, the ARCOS process, which is supposed to keep track of this, but the DEA basically told us they get their information late if they get it at all. Do you feel any corporate responsibility in your businesses to report something that on its face is so outrageous to law enforcement?
Senator, we take our responsibility to report to the ARCOS database very seriously. It's a very important issue for us. We are very pleased with the new functionality that was put forward in the support
Excuse me, didn't Mr. McDermott say that it's a matter of months before they get the information?
It is, sir. It's either monthly, he said 30% or monthly.
So if there are some massive, your distribution company sends some massive amounts of opioids to a tiny pharmacy in the middle of nowhere, Illinois, you believe your responsibility ends by contacting ARCOS?
No, sir. I mean, we have a responsibility to prevent diversion. That's our obligation under the Controlled Substances Act.
I would thank you, and I would hope that that would mean you would contact law enforcement and say, time out, this is not right. Something just happened here. We want to report it. You feel a corporate responsibility to do that?
Yes, sir, and many of our companies do that on a
And the
regular
pharmacy itself, I mean, there's got to be some people working at the pharmacy who may look at the back door and say, they delivered what?
Yeah, absolutely. And our responsibility is not to report to ARCOS, but we report to prescription drug monitoring programs that are overseen at the state level. So the turnaround time on those varies. Some are every 24 hours. NCPA supports as frequent a reporting as possible, but that is our members' responsibility to report those controlled substances they're dispensing.
I think we're on a roll call on the floor, so we maybe have to cut it short.
Thank you.
It's not a reflection on our respect for you being here today and what you represent. Thank you very much.
Yes, thank you. And I'll just wrap up. Dr. Stein, you've talked about alternatives, inadequate alternatives for prescription opioids and the barriers that are there for effective treatment for opioid misuse. What immediate policy changes do you recommend to increase alternatives to prescription opioid medications?
I think we need to make sure we are developing, disseminating, and really financially supporting and paying for alternatives both in the short term and long term. In the short term, we know that certain types of pain procedures, such as wisdom teeth being removed, we don't need opioids for, and we need to make sure we're using those. For more chronic pain, we have things like physical therapy. Over the longer term, though, we need to sort of develop and make sure insurance is covering a whole variety of treatments that are effective for people that have pain. Pain isn't going away. It affects 20% of U.S. adults and impairs 1 of 12 so much that they can't do their daily activities. We need to be able to manage that.
Yes, I appreciate that very much. And Ms. Thaw, your testimony, really, if you go through the written testimony that you've provided, there are some powerful prevention success stories from drug-free communities. And how can Congress best support those types of programs?
Thank you so much. Just by exerting leadership, and I think that it's also important that we have more communities that are trained and have the capacity to get those types of outcomes. Tiny bits of federal money, $125,000 a year with a dollar-for-dollar match is basically all that they get. So it's an amazingly great investment of scarce federal resources. And as Senator Kuhn said, that we got a tiny bump up yesterday, but literally, for every $1 million, we end up with another 8 to 10 grants. So
very good. Very good. And I do apologize, folks. We are going to cut you short on your panel today. I think our other members have all fled to the floor. So we will also flee to the floor. But I do want to thank you for your important input. We do have your written records, and those are submitted for the record. We'll make sure of that. And I appreciate the time and attention that you've given to us. Thank you so much. We will keep the record open for 1 week for all members wanting to submit items for the record.